Again, I'm Erin Zahradnik. I am a geriatric psychiatrist. I am a neuropsychiatrist, and I do palliative medicine also. So I'm going to be talking about palliative management of neurodegenerative diseases and also about some neuropsychiatric symptoms that you might see in palliative care. All right, so no disclosures. So just briefly, some objectives. So I'm going to talk about specifically about palliative care in neurodegenerative diseases, about communication methods that can be used, about things like depression and grief reactions, and then some treatment options also. Okay, so neurodegenerative diseases. So what do I mean by this? So these are in general diseases that involve the destruction and loss of neurons. And most of the time they involve loss of cognitive ability and the loss of motor function. Not always, sometimes you get one or the other. And some examples, and this is not an exhaustive list, are ALS, multiple sclerosis, Huntington's disease, things like Parkinson's and Alzheimer's, vascular dementia, frontotemporal dementia, Lewy body dementia, and on and on and on. Okay, so in this group of diseases, there are often some pretty unique challenges in palliative care. So one is communication, just the ability to actually talk to the patient and be understood and to have them understand you. Provider knowledge gap. So some of these diseases are maybe sort of common within palliative medicine, but are less common within the general population. So something like ALS, many ALS patients will end up in palliative medicine and eventually into hospice. But to the community neurologist, this is a really rare disease, and they might not even have a lot of knowledge about what happens and what exactly the prognosis is. Family, patient, and caregiver knowledge gap. So you can't really expect a layperson to understand a lot of the specifics about these diseases. So a great deal of work has to go into just educating them and really just teaching them about what the disease is, what happens during it, and how they can work with their loved one. Things like isolation, especially in the less common diseases, feeling like no one they know has it, that they're all alone. And in physical isolation too, if they have mobility problems and can't actually get out of the house. Stigma. There is still some stigma with dementias. Sometimes people distinguish between having dementia and Alzheimer's. As we know, Alzheimer's is just one of the many dementias, but sometimes there's kind of a people are fearful of this or look down on this and don't really want to hear about it, and so people who have dementia don't want to admit it, and so that's another way to isolate themselves and keep them away from support, really. And then another issue is the timing of advance directives. When is the right time, and how do you balance between giving the person time to process their disease, but also making sure to talk about ends of life sorts of things, advance directives, and treatment goals while you can still communicate okay with them. Okay, so more specifically, when I talk about communication challenges, I'm talking about things like impaired motor function, so aphasic speech, where somebody can't understand language, somebody can't speak very well, and this can be because of having a stroke, it can be because of a progressive dementia, it can be a motor problem like in ALS, where they really just can't move their tongue and produce the words very well. You can get issues with cognitive impairment and communication. They can't remember what you say, or they hear something that requires a lot of steps, and they get overwhelmed and they can't really process the instruction. And a lot of times you have to rely on family members for interpretation. They're around the patients the most, and sometimes they can tell better what the patient is saying. There's also devices and things like communication boards. The little graphic is just a picture, one of many sorts of things that you can use. People can point to it. Sometimes, even in dementias, people have trouble thinking of the right word or pronouncing the right word, but they still know what they're trying to say. And so having a picture of different things can be helpful. They can kind of point to it. Okay. And then sometimes you get issues where you're not quite sure if the patient can comprehend appropriately. And so this graphic on this slide just gives you sort of some suggestions to deal with that, to ask the question in several different ways. I think the last one, language comprehension, can be really important, to ask sort of a nonsensical question in just a normal tone to see if somebody is able to answer it appropriately or to look at you like you're crazy, to see if they're really comprehending, because people can have their kind of social affect intact even when they're not understanding. They can smile and say yes and nod and no and look like they're understanding you, but actually not be able to. Okay, so I have embedded in this some chat questions. You can save these until the end of the talk, or if you have examples or things that you want to talk about related to it now, you can feel free and type in the chat. So at this point, I would just wonder, how would you approach an advanced directives conversation with the patient who can no longer speak? A lot of times people kind of wait too late, or they have a massive stroke and they have a lot of trouble communicating, and so you really want to know what sorts of things they want and what their values are, and they can't speak anymore.
Erin, if somebody does write in a question, if you can read it out loud, that would be great.
Okay, so yeah, so Brittany said use a surrogate decision maker. Yeah, I mean, that's definitely an option if they have a surrogate decision maker and they've talked about these things. The issue is in a patient who is, or who you suspect may be competent, what else can you do? Yeah, and Nicole says, I want to know what they can understand, or if other methods of communication can work for them. So yeah, this is where things like the picture boards come into play. Yeah, via writing, if they can write but they just can't speak. Sometimes that can happen in strokes. So that's another option, definitely. I mean, and another thing too, if their speech is just so garbled, you really can't understand what they're saying, but they do have, a caregiver or a family member. I wouldn't, but sometimes it's the caregivers who spend the most time with them, who can kind of translate for you in a way that's also can be helpful. Okay, so I'm just going to talk about a few diseases that we could see in palliative care. So I'll talk about ALS first. So I deal with a lot of ALS patients, so I'm a little bit biased. So it's a progressive fatal neurodegenerative disorder. It leads to total functional impairment. Usually people die from respiratory failure because their respiratory muscles no longer work. Mostly it's sporadic, and sometimes there is a genetic component to it. But there's a lot of symptom management issues within ALS just to be aware of. And these can come into play also with a lot of the less common neurodegenerative diseases. So respiratory decline. Palliative care is really be helpful when you're thinking about decisions that involve things like a BiPAP or a PEG, or if they want to get a trach, if they want to be on a ventilator, what that looks like, how that fits in with their perception of themselves, and eventually, how hospice could maybe help with them, depending on where they are in their disease state. Sialorrhea, so that's drooling. This is another big issue in ALS, and it just comes from weakness of the muscles around the mouth. So there's a lot of various treatments for it. Mainly they're anticholinergics. But this is really something to monitor, because this can be embarrassing for the patient and contribute to them feeling isolated. I mean, nobody wants to go out if they're drooling all over. So this is, something that can really improve their quality of life if it's treated. Issues with weight loss, definitely, because there's eating issues. And so this also can involve conversations about feeding tubes and things like that, whether people want them or not. The difficulty with ALS too is that it's so fast, it progresses so quickly that people really don't have very much time to get used to the idea of having this disease when they're already faced with decisions like, should I get a feeding tube inserted? Do I want to do BiPAP? So this can really hit people hard. So things like pain, that's a real common issue in many, many different diseases in palliative care. And then there's a lot of neuropsychiatric symptoms that come into play with ALS, and also a lot of the neurodegenerative diseases, you'll see these things. So anxiety and depression, obviously. Normally having kind of a period of grieving around the time of diagnosis is normal. You will need to have time to just adjust to this total change in your whole outlook. Like I said, 90% of the cases are sporadic, so this often just comes totally out of the blue. They've never heard of this disease. They are maybe winding down their working years, looking forward to retirement, or maybe they just retired, or even they can be younger even, and all of a sudden they're faced with this disease. And prognosis of ALS is like life expectancy is about 2 to 5 years from times of diagnosis. So it's pretty fast. So anxiety and depression are not unusual. Pseudobulbar affect. You can also see this actually in vascular dementia, especially. I would keep an eye out for this. So it's just spontaneous laughing and crying, or really excessive laughing or crying. Somebody is watching TV and a sad commercial comes on, and maybe if somebody's really sensitive they might tear up, but people have pseudobulbar affect, they'll just start sobbing. Just kind of intense reactions to things that are not how they would normally be acting. And then frontotemporal dementia is also another fun thing that comes along with ALS. Or I'll mention this later too, you can have frontotemporal dementia on its own. And that just comes in with a whole lot of other issues with cognition and impulsivity and things like that. Okay, so I touched on this before, functional loss. So again, this diagnosis really, for the most part, comes out of the blue, and it's very fast. And so people might experience new deficits, every month, even every week sometimes. And they come in and their foot is kind of weak, and a month later their lower leg is weak, and a month after that their whole left leg is weak, and they're having to use a cane within 3 months. It's not always quite that fast, but it definitely can be. It's constant changes without really a chance to adjust. So I'm going to touch now on dementias, because these are pretty common, as we know. and there are many different types of dementias. So Alzheimer's is for now considered the most common, um, and vascular dementia is the second most common. Honestly, you can make a good argument for mixed dementia being the most common or really pretty close up there. So that's kind of a combination between Alzheimer's and vascular dementia. So vascular dementia comes along with risk factors like hypertension, high cholesterol, things like that. So you don't even have to have had major stroke. So it's a pretty common diagnosis. And then there's dementia with Lewy body, which can look a lot like Parkinson's disease because there's some motor symptoms. And then there's frontotemporal dementia, which usually happens when people are a little bit younger than the other dementias. And again, it is not necessarily associated with ALS. So at this point, dementia patients are definitely increasing within palliative medicine. They used to be a pretty small population, but there's been a lot of work done, and that's the tides are changing, fortunately. But still, overall, people who have dementia are less likely to have advanced care directives. This is a one where timing is a big issue. How do you know when to talk about these things? How do you know when to say, we need to do this, or it's going to be too late? Prognosis of dementia is difficult to really determine. So a lot of people with dementia, especially more advanced dementia, have inadequately recognized and inadequately treated pain and non-pain symptoms. A lot of this is just because of communication problems. And then also people with dementia are just prone to developing complications from medical procedures and hospitalizations. And the big one of this is delirium. And delirium is really actually a dangerous outcome for older adults, especially people with dementia, because it really can have a permanent effect on somebody's cognition. If you have dementia, you go into the hospital, you end up developing delirium. Eventually the delirium can clear, but your baseline is probably never going to return to what it was before. It's probably going to be a step down. So avoiding any sort of unnecessary procedures and hospitalizations is really important for these patients. So symptoms that interfere with quality of life, behavioral problems. Behavioral problems. Not just the patient's quality of life, but the caregiver's quality of life. Sleep disorders, really common, also really impact caregivers. Eating difficulties, whether it's loss of appetite or difficulty swallowing or just forgetting that they're hungry, anything like that. There's a lot of issues. Caregiver support, it's a huge, huge factor. A lot of people would prefer to stay at home as long as possible, and to do that, they need caregivers. And since most of the population can't afford to hire private 24-hour caregivers, understandably, family really comes to play a big part in this. And so they need a lot of support because this is very difficult, just in education about what dementia is and what sorts of things the patients do and what that means. And just support in that is difficult. Hooking people up with community caregiver support groups can be really helpful for them. And even just, being a listening ear for these caregivers can be really, really helpful. So goals of care. Figuring out what somebody's goal of care is, but overall, generally, you want to reduce the burden from having to take 20 different medications, having to do a lot of procedures and hospitalizations. So you really want to kind of help the patient and family look at the big picture instead of, mom is, feeling a little bit nauseous, or mom is, she has a cold, instead of going through every possible procedure and workup that could be done. You kind of weigh the risks and benefits. is this probably something serious? If her doctor is worried that for some reason this could be a cancer, is this something that we would want to treat? Would we want to put her through chemotherapy and surgery and all of that? Or would that be off the table? In that case, maybe the family would not really want to pursue too much. And remember, there's always that risk of delirium from anything that they do, and that's always going to impact the patient. And then just kind of reiterating with the families and the patients too about their expectations as the disease processes, especially the families, like what do they think is going to happen. A little bit of specifics. So Alzheimer's disease, it affects millions and millions of people worldwide. The prevalence is expected to double every 20 years. The predominant type, there are variants of Alzheimer's, but mainly you see the amnestic type, so short-term memory loss, language issues like word finding difficulties, forgetting names, word substitution, saying kitchen instead of chicken, or things like that are pretty common. So vascular dementia, and I put the little tiny graphic, I don't know how well you can see it, that kind of shows the mixed dementia, where there's vascular risk factors and also possible Alzheimer's, and that's a really common form. Vascular dementia can occur in people who have strokes, but also in people who don't have strokes, but who usually have some sort of vascular risk factor, and it's pretty hard to find somebody who doesn't have a vascular risk factor. Things like high blood pressure, hyperlipidemia, coronary artery disease, peripheral vascular disease. These are common things. And so, most people have vascular risk factors. The classic characterization of vascular dementia is a stepwise deterioration. And you see that more in people who have stroke. So they'll be going along okay, and then they'll have a little stroke, and then their baseline will drop to a little bit lower than it was before. And they'll continue on at the same, and then they'll have another vascular event, and their baseline will drop. It kind of depends on what is causing the vascular dementia. So you can have language deficits. Certainly, if you've had strokes, you're going to have language deficits. Well, it depends on where the stroke is, but most likely. You usually have a lot of memory problems, though, and then also behavioral symptoms. So things like irritability and depressed mood and things like that are pretty common in vascular dementia. Okay, so Lewy body dementia. So I wanted to mention this one because it comes with these fun visual hallucinations a lot of times. So if you see somebody who's having visual hallucinations, that is very unlikely to be a primary psychiatric thing. So people who have like schizophrenia and things like that, where they have psychosis and they have hallucinations, they'll have auditory hallucinations. They could have delusions where they think people are coming after them. They can have tactile sensations where maybe bugs are crawling on them, but they're probably not going to have visual hallucinations. Visual hallucinations where they're actually seeing something is really more often something organic, or like their morphine dose is way too high, or something like that. But this is one where you definitely have visual hallucinations. It's one of a classic triad, although the triad has become a tetrad, really, because you get the hallucinations, you get fluctuating cognition, so sometimes you are more alert and sometimes you are less alert. You get Parkinsonism, so it can mimic Parkinson's disease, so you get some gait disturbance, although usually no tremor. Then also the other new thing on the tetrad is this REM sleep behavior disorder, which is pretty common. A lot of the times it's people who start kind of acting out their dreams. So they start kicking around. In worst case scenarios, they smack their spouse. They knock lamps off tables, they fall out of bed, they can get pretty wild, and that's part of the disease. But it's treatable, so you just treat it with benzos, and they get better. Well, that part gets better. And then the visual hallucinations also, so this is sort of interesting. So you just use something like donepezil, like Aricept, and that actually makes the visual hallucinations go away. So this is the one case where it's actually very useful. Right, so frontal temporal dementia. So it's the most common cause of dementia under age 60. You have some people who have early onset Alzheimer's disease, which is anything before the age of 65. But it's really less common. You see that more in people who have a strong family history of Alzheimer's disease. Other than that, frontal temporal dementia is more common. And like I said, it can come along with ALS, but it doesn't have to. The big thing with frontotemporal dementia is that you feel like they've had a personality change. They're not the person they used to be. And you can see all sorts of things like impulsivity, pretty big behavioral changes. And in some cases, there's some variants where you can have trouble speaking and some word finding difficulties. But the big thing is the personality change. You ask the family members, do you feel like his personality has changed, in the last few years? And they'll say, yes, I do. And that gives you a big red flag that it's frontotemporal dementia. So you can kind of help explain to them, this is part of the disease. It's not that he is necessarily depressed, or he's not bipolar, or he doesn't have all these other sorts of things. This is part of the disease. Parkinson's disease. So this is one of the more common ones. You don't always have dementia in Parkinson's disease, although you certainly can. It's more often a functional impairment. It's a movement disorder, so the tremor, the trouble moving, kind of the rigidity, and there can be discomfort that comes along with it. So palliative medicine can be really helpful in kind of helping with that, and then it's also just helping people connect with community resources, because the Parkinson's Disease Foundation does a lot of community sorts of classes. They have boxing for Parkinson's disease, they have dance for Parkinson's disease, things that can really help people feel better and kind of get out of the house and do things and forget about, just sitting around and feeling bad. Okay, so I found this slide actually that was oriented towards Parkinson's disease. So like any of these dementias, it's sort of hard to figure out what you do for palliative care because they can be really slowly progressing. And so this is giving you the outline of looking at it through event-driven milestones. So kind of, if we see the presence of dementia, we start to worry about cognitive impairment. How does that affect what sort of advanced directives we want to talk about with them? They're having sleep disturbances. If you start to notice a lot of caregiver burden, why is that happening, and what can we do to help with that? So increased symptom burden. A lot of this is also going to be working with the neurologist too, and figuring out what you can do to help them. And so, like I said, those classes and things can be helpful for the patient because it helps them kind of feel a little bit more in control of themselves and of the disease. Okay, so again, this is another question to consider. So this slow progression of dementias. So how do you know when the right time is to talk about end-of-life issues? I don't think there's necessarily like an exact right answer for this. But if you have ideas, feel free to put it in the chat, or we can save it until later, whatever you want to do. Yeah, I think that's a really important point that Kelly just made. So basically, if the person still has enough cognition, it would be really important to have the advanced directive discussion while they still can participate. That's super important. You always run into patients who I think actually most people would prefer to put it off. They think, oh, it's too early, I don't want to talk about this, I'll talk about this later. and then, it becomes later and they want to talk about it even later. So, sometimes you have to kind of gently prod people and remind them that it's better to talk about it when they feel good and when they have time. Yeah, definitely. So Nicole said it does depend on the patient, definitely. But earlier is better. And you're right, yeah, you may have to bring it up often. I mean, you can do it in increments. It's not like you have to sit down there, right, and be like, okay, so do you wanna do DNR? Do you want CPR? Do you want this and that? It's really just talking about what's important to the patient, who they are as a person, to get a better idea of that, because that will help you sort of guide them towards advanced directives, end of life sorts of decisions that are in line with them. So if somebody is, independent, they really value that. Saying, well, if you have a disease that you might end up, intubated for some reason, it sounds like independence is really important to you, and being stuck on a ventilator in a bed is not in line with what you value. This is an option, but it doesn't sound like it's really what you would want to have happen. So yeah, I mean, slowly in increments, but definitely earlier is better. Okay, so I am going to take a little turn and talk more about neuropsychiatric symptoms and psychiatric symptoms. So, neuropsychiatric symptoms, by that I mean anything that happens in dementia. So, apathy, irritability, depression, anxiety, agitation, paranoia, delusions, hallucinations, etc., etc. And it happens in up to 97% of all dementia patients, one of these at least. So, I mean, essentially every dementia patient is going to have something. And a big thing is working with the patient and family and what their goals are in terms of staying at home versus going into a facility. Is a facility possible for them, or are they just really adamant about wanting to keep mom at home? And then sedation versus control of agitation. So, unfortunately, we don't have the greatest medications to control agitation. The ones that we do, a big part of how they work is by, kind of possibly sedating the patient a little bit. We don't want to totally knock the patient out, but we might have to have a compromise, between them becoming really agitated, which is also not comfortable for the patient, and then them, sleeping more hours a day than you would ideally like, but also not being agitated. Okay, so this is a very busy slide. So treatment of neuropsychiatric symptoms. I mean, so antipsychotics have the black box warning. The black box warning is kind of sounds scarier than it really is. I mean, really what it's saying, what it goes down to, if you read the literature that it's based on, is that in people who have specific risk factors, and mainly they are cardiovascular and cerebrovascular, and mainly a history of heart attacks and strokes, especially recent. There is an increased risk of death if they're on antipsychotics for behavioral issues and dementia. And by increased risk, it's like a 2% increased risk of death, which is statistically significant, so it's definitely there. So I would, hesitate a little bit if somebody just had a recent stroke, but also it's weighing the risks and benefits. Is this person hitting people with canes and barricading themselves in the house and no caregivers can get in? Well, that's really not going to do wonders for their quality of life. And so, you kind of have to, what is the risk is overall pretty low. The benefit could be really great. So, just talking with the family and seeing what they're willing to do and what you're willing to risk also. And you really have to just talk with a geriatric psychiatrist about what antipsychotics to use. The literature isn't very good. There's a few studies, but they're very different. They use different doses. They're not the greatest. It honestly doesn't really matter which one. The goal is really just to calm a person down and make sure that they're not endangering themselves. Sometimes people might use Depakote. The evidence is mainly that it's not effective. So this is kind of palliating the doctor instead of the patient. So I would just skip this. Some SSRI. So if you have a patient who has a more mild dementia, who is maybe kind of more irritable than they used to be, this would be a great option to try an SSRI. There is some evidence that it can be helpful. It's certainly not going to hurt. It's certainly worth a try if somebody is not to the stage where they're, being combative and there's violence. So it's definitely a possibility. And then the non-pharm treatments, which are really probably the best ones. So things like behavioral interventions, a lot of this is with the family, just teaching them how to talk with the patient, that mom isn't doing this to hurt you, it's part of the disease process. Music and art therapy, so even just playing something, some kind of music that the patient really likes and is calming or is reminiscent of their childhood. Quiet environments, lots of people and noise are going to agitate people. And then again, caregiver education, that's the most important part. Sometimes you don't even need to use medication if you've done a really thorough job of caregiver education. So I think palliative medicine can be really, really helpful in this area because, if we can avoid using these medications, then that would be ideal. I do want to touch on, so I didn't put it in the slide, but there's also medical marijuana, which there's no evidence for or against. So I can't really tell you what is recommended. It's not out of the question. It's just not known. It's kind of like a last line possibility, but it's there. Okay, so depression and dementia. So depression is thought to be present in about 10 to 20% of patients with dementia. So if somebody has mild dementia, well, that's fine. You can just ask them if they feel depressed. That's easy. If they have more advanced dementia, that's a lot more difficult because they're not necessarily understanding you and they can't necessarily report accurately to you. And the other problem, and this is actually with any disease that we see in palliative medicine, is that a lot of the sort of symptoms of depression, so sleep problems, appetite changes, lack of energy, apathy, are also just part of having a serious illness, having a dementia, and so they're not very accurate. You can't say, oh, this person's sleeping a lot, they're not really eating that much. Well, they also have pretty significant dementia, so you also see those symptoms in non-depressed people. So, I mean, probably the best way to go about this is if you suspect depression, if the patient has a history of depression, then you can err on the side of thinking that maybe they do have a recurrence of depression. It's more likely. That's the biggest risk factor for depression, is a past history of it. If they don't have any history of it, then it's more difficult, and you might have to just talk with your friendly psychiatry colleague. Okay, depressive spectrum. Okay, so I want to talk about this because I think we see a lot of patients who we're concerned about them being depressed, or the if you do hospital consults, you're concerned, or the primary team is concerned about them being depressed because they have a serious illness. It's a complicated area. So I just included the symptoms. This is from the DSM-5. The bolded part at the bottom of the slide, significant impairment in social, occupational, or other area of functioning. So that's really the critical issue. If somebody is having all of those symptoms of major depressive disorder, which again can also be symptoms of the diseases that they might have, but it's not, they're still, reaching out to friends, as much as they can. They're doing things that they can within their means, then I would really not call them depressed. But if they are totally isolating themselves and not acting at all like themselves, so that's a significant impairment in social functioning, then I would be more concerned for depression. But that's a key thing I think that's missed sometimes, is that you really have to have an impairment in some area of functioning. I think that's especially important for people with serious illnesses. Okay, so when you're thinking about treating depression or anxiety within palliative medicine, um, prognosis is really important to consider. So this is the idea of the big picture. If they have a chronic progressive illness and their life expectancy is, many months to years, well, fine, you can use the usual medications. But if their prognosis is less than that, then you probably want to look at medications that have a quick onset of action. So things like stimulants or that target specific symptoms. So if they're having a lot of trouble sleeping, maybe something that's really going to help them sleep. Instead of, because you don't have the time to wait for an antidepressant to kick in. And then psychotherapy. So prognosis is really important. I mean, I think in palliative medicine, a lot of what everyone does is a little bit of brief psychotherapy, because a lot of that is just sitting with the patient and listening to them, and just being there for them and validating whatever emotions that they have. So more formal aspects of psychotherapy. Again, prognosis is just really important. You can't send somebody for long-term talk therapy if their prognosis is short. Nothing's going to happen. I mean, even CBT, which you have to have some cognitive flexibility, so no dementia patients, takes at least like 3 months to complete. So things that are specific for palliative medicine, like dignity therapy, can be really helpful, because they're meant to be done within like 1 or 2 sessions, and they're meant to really focus on somebody's legacy and reminding them of who they are outside of the illness. Okay, yeah, so again, pharmacological treatment for depression and anxiety. Again, first choice is whatever worked in the past. And then I just kind of included a bunch of possibilities. There's not really a wrong answer, honestly. In terms of SSRIs or SNRIs, every psychiatrist has their preference, and that's what they use, and it doesn't really matter. So whatever you're comfortable with. Okay, so grief rather than depression. So I think this is an important thing to touch on, because you are talking about a normal reaction to loss or anticipation of loss. I'm not talking about death in terms of grief. I mean, that's possibly part of it, but mainly I'm talking about like loss of independence, loss of function, loss of what kind of person you used to be. All these kinds of things will happen, and they can manifest as they might look on the outside like depression, but really it's just grieving, having the disease and grieving the loss of what you thought life would look like. And the importance of this is that you're not going to treat grief with medication. I was going to do a little case just about how much time do we have? We could do this briefly. Okay, so I'm just going to read this really quickly. Okay, so this is just a case. Just going to illustrate the ideas of grief. So we have like a 45-year-old woman. She's married. She has 1 young daughter. She was diagnosed with ALS 2 years ago. She's meeting with her team, and she becomes really tearful. And she confesses that she is really worried about loss of function and independence, worried about spending time with her child, worrying about what's going to happen when she's gone. And in a later visit, you see her and she's talking about feeling numb. She's feeling hopeless about the future. She's saying, I just wish I didn't have ALS. I wish I didn't have it. She appears depressed, but when you ask her, she denies it and she says, I'm fine. And when you ask her more about how things are going at home and how her daughter is and what she's thinking about in terms of her daughter, She just becomes really irritable and kind of standoffish. And you meet with her a little bit later even, and again she's just kind of withdrawn, irritable. Her family, talks to you, or pulls you aside and says they're worried that she's given up, and she's becoming less interactive with her children. Could this be depression? Sure, it could be depression. Could it be grief, though? It could definitely also be grief. It can be hard to distinguish between the two. But I think working with a patient and just letting them talk about it, sometimes you can just sit there in silence, even if a patient is standoffish, and usually they'll start talking eventually. And in this case, I'd really just be concerned about what she thinks, or how she's feeling about her daughter, because this is a complicated case, and most people aren't textbook cases. But I think grief is definitely a real possibility in something like this instead of depression. All right, so this is kind of a summary slide on different approaches. So again, there's lots of approaches if you're worried that somebody's depressed or anxious, or if they're grieving or you're not quite sure. Psychotherapy, complementary medicine, spiritual counseling, hobbies. It's really important to remind the patient that they're a whole person. They're not just this sick person. They're not just this disease. They have all these other aspects to themselves. Take-home points in communication. So communication is often a barrier, a functional barrier. I'm running out of time. Okay, good. Okay, now we got to the questions. So does anybody have any questions? Do you have any comments on the previous chat questions, which were about timing of advanced directives and about communication in a patient who can't really speak, or anything else that you're thinking of? Okay. So one question was, thought Lewy body dementia was always associated with Parkinson's, but that's incorrect. Yeah, it's not necessarily associated with Parkinson's. So Parkinson's disease patients can have Lewy bodies, like the little actual inclusion bodies, if you do a brain biopsy, but they're two separate diseases. That's why Lewy body, you don't always have all of the motor impairments that you do with pure Parkinson's disease. Okay, and so then other comments, large frontal lobe tumor. Yeah, we've used laser neuropsych a lot. It's been helpful. Also, patients, yes, that are able to PT, OT, and speech therapy are fantastic. Yes, absolutely. So, yeah, so I keep talking about ALS patients because that's who I work with, but I think one benefit is that it's pretty common to have multidisciplinary ALS clinics where you have PT, OT, speech, nutrition, everyone together. And so I think the more hands you have on deck, everybody is part of the team that is working to really help you out, I think can be really, really helpful. I know of reliable websites for support groups for caregivers. So, yes, so it depends. So it depends on what sort of disease they have. A lot of the major diseases have foundations. So the Alzheimer's Disease Foundation is amazing. They have chapters in pretty much every major city, and they offer classes and support groups for patients and for caregivers. Parkinson's Disease Foundation also has pretty good support options too. But also there's community issues, like the geriatric clinic at University of Chicago. There's a caregiver support group. So actually geriatric clinics anywhere where you are, in hospitals and things like that, sometimes they do have support groups for caregivers, or even just the hospital themselves will have caregiver support groups. All right. Well, thank you all for being here, and thank you for your questions. And my email's on the screen. Okay.